Good day, everybody. This is Chris with the Ancient Scholar. I hope this video finds you all doing well. So what I'd like to do before we head off into the holiday weekend is a quick clinical vignette. And this is going to be relevant mainly for pre-hospital providers, but I think it may also have some crossover for people that are taking care of acutely ill and injured patients. And I just want to have a little discussion on pressors or vasopressor therapy and talk a little bit about some of the common options that are out there and some of the clinical implications for using some of these options. It can be kind of confusing for some of us, particularly if we have multiple tools in the toolbox. I want to kind of spend a little bit of time talking about what these tools are and kind of how we can look and conceptualize using these specific tools. Vasopressors are primarily agents used to increase blood pressure, and there are a couple of different mechanisms. So if you remember, blood pressure is primarily a function of two major physiological parameters, at least for our purposes today, and that really comes down to the systemic vascular resistance. So that is kind of think of that as the pipes of the system and how constricted or relaxed those pipes are. And when they're really constricted, there's a lot of resistance. And you might think that the more resistance, the worse off we are, and that's not necessarily the case. You need to have a balance, right? If you are super open and your pipes are open and dilated, the heart is going to have a hard time pumping blood through this vascular system that is too large and has too little vascular resistance. And likewise, if there's too much vascular resistance, there's too much resistance that the pump has to pump against, that can be a problem. So it's really a balance of systemic vascular resistance and cardiac output, right? What is actually coming out of the left ventricle of the heart and going into the aortic arch and out into the body. And cardiac output is primarily a function of inotropy, how the heart is contracting, how well it's contracting, and how much contractile force there is, and how much blood is getting contracted out of the heart per contraction, right? So the left ventricular ejection fraction is a good reflection of that. So it's really a function of inotropy and chronotropy, or heart rate, right? And the classic formula for cardiac output is a product of heart rate and stroke volume, and so that's what we're talking about there. So when you have dysfunction of these two mechanisms, or perhaps one of the mechanisms, systemic vascular resistance or a cardiac output alteration, you run the risk of developing hypotension. And most importantly, if this hypotension is associated with poor end organ perfusion. And there are some basic parameters that a lot of us look at. A lot of people use the mean arterial pressure, which I think is a good quantitative indicator of or reflection of end organ perfusion. Most people shoot for a threshold of around 65 millimeters of mercury, and if you are consistently less than that, then there should be some overall concerns about end organ perfusion. When I say end organ perfusion, I'm talking about perfusion to vital organs such as the kidneys, brain, the heart, and other vital areas of the body. And some people say systolic pressure of less than 90, and there may be some other physiological parameters. And I think you always want to pair quantitative parameters with just the overall patient's condition, right? Does the patient look like they're having some sort of shock state, some sort of end organ dysfunction? And do you clinically see that, right? So altered mental status, decreased urinary output. Do you see alterations in labs such as a metabolic acidosis with a anion gap that's elevated and a lactate that's it's increasing? Or do you see parameters of specific end organ dysfunction such as the kidneys, right? The BUN and creatinine are elevated. You have oliguria or anuria, right? Those kinds of things. you also want to marry those things with these quantitative values like mean arterial pressure or systolic blood pressure. Okay, so now we kind of have an idea of what hypotension and hypotension that is associated with alteration of end organ perfusion. Where do vasopressors come into play? Well, vasopressors really come into play when you are attempting to fix some underlying problem, or maybe not fix the underlying problem, but provide some support while you identify and fix underlying problems if you can, right? So is this a systemic vascular resistance problem, or is this more a cardiac output problem, or is this a problem that involves both impaired systemic vascular resistance and impaired cardiac output? So when we talk about some of these agents, I suppose I'll conceptualize them on a continuum of receptors. So let's start on one side where it's pure alpha or more alpha, and then we'll work our way over to more beta effects. So we're talking about sympathetic receptors. So when we talk about agents that have more alpha effects, the common agent that we may administer that has pretty much pure alpha-1 effects, so the alpha-1 receptors are primarily located in smooth vascular muscle, is going to be phenylephrine or neosynephrine, right? That's a classic one. Neosynephrine has fairly limited emergency medical use. There are some cases where I think phenylephrine actually plays a role. Because it's a pure alpha-1, there are some very specific situations where you may consider using this. First and foremost, it's pure alpha-1, so it's going to increase systemic vascular resistance, right? So you need to ensure that if you're using this, the patient has a good cardiac output. So the source of their hypotension can't really be due to any underlying cardiac output anomalies. So this would be a terrible agent in the setting of, say, cardiogenic shock, or say septic shock where there is some sepsis-associated cardiomyopathy, which actually is fairly common. This is not an uncommon finding to have myocardial depression in the setting of sepsis, severe sepsis, and septic shock. All right, so you need to have good cardiac output, but a low systemic vascular resistance. And there are some special situations where this may be a good agent. First of all, if you have a patient who is hemodynamically stable prior to intubation, and they don't have some terrible metabolic or hemodynamic problem that they're being intubated for, right? So maybe this is, say maybe an isolated head injury, or, some specific issue where the cardiac output isn't impaired, and the patient becomes hypotensive after the intubation, and you have good reason to suspect that a hypotension is due to the vasodilatory effects of the induction agents or the sedative agents, or possibly the analgesics, right? If you're having to administer, say, large amounts of propofol post-intubation, or you're giving large amounts of benzodiazepines and perhaps opioids, and you suspect that that's the proximate cause of the hypotension, that's primarily going to be a vascular problem, and a phenylephrine or neosynephrine may actually be a good agent for that particular patient. In addition to that, one other situation that you might run into is aortic stenosis. So you have stenosis of the aortic valve, and you're looking for an agent to support the patient's blood pressure. These patients tend to be highly preload dependent for their blood pressure, and so many of the vasopressors can impact preload to varying degrees. You actually can get some vasodilation with some of these agents. Even agents like epinephrine, you may get some limited vasodilation. And so if you really mess around with a preload too much, this can be very problematic. And so if you're trying to support someone with aortic stenosis, phenylephrine or neosynephrine may be a good agent for those particular patients. All right, so that's phenylephrine, pure alpha-1 agent. Now, the next agent that I'm going to talk about is a pretty powerful alpha 1 agent, but it does have some beta 1 crossover. And so I'm going to mention that. All right, so we've gone from pure alpha, now we're adding a little bit of beta into the mix. And this is kind of a standard go-to pressor that's good for undifferentiated shock, right? You're not quite sure what's going on. You want to support the patient with a vasopressor. This is actually a pretty good all-around vasopressor, and this is norepinephrine or noradrenaline. It's a good go-to, again, for most types of undifferentiated shock because it has some, not only does it have pretty good alpha-1 activity, more alpha-1 activity than anything, so you're getting some vasoconstriction, but it also has some beta-1 effects, so you're getting the inotropy and the chronotropy. You're going to get a little bit of contraction, a little bit of increase in the heart rate, not substantial compared to other agents, but you're still going to get a little bit of crossover. So norepinephrine is kind of a good all-around agent, and it may even be a good consideration for cardiogenic shock, although we often like to give agents that are more beta, that have more beta effects that can help with contractility, such as dobutamine or maybe something like milrinone, which isn't technically a vasopressor, but it does impact contractility. The problem with those agents is they can impair preload, they can cause some vasodilation, and that can really impair cardiac output. So it's kind of nice. You can start some norepinephrine, get their hemodynamics supported with that norepinephrine, and then add some dobutamine or milrinone in on top of that to support, to give them that cardiac support. So that's kind of where norepinephrine fits into the picture. Norepinephrine is often considered the go-to primary, or the primary go-to agent for treating severe sepsis or septic shock, because you are getting the alpha effects, and you're also going to get a little bit of beta, because we know, again, that's myocardial depression can occur in the setting of severe sepsis and septic shock. All right, so that is norepinephrine. And then I think the next common pressor agent is an agent that has a good mix of both alpha and beta effects, alpha 1, beta 1, and beta 2 effects for that matter. And so it is the most sympathetically promiscuous drug, and that, of course, is epinephrine or adrenaline. You're getting both alpha 1, beta 1, and beta 2 effects. Epinephrine is going to be the go-to agent when it comes to treating anaphylaxis, and it may be the go-to agent in the setting of septic shock when you have severe cardiomyopathy, where you want the increased inotropic support that comes with epinephrine over something like norepinephrine, or if you want to increase the heart rate, such as a symptomatic bradycardic rhythm, dysrhythmia, for example, epinephrine may be the go-to agent. I will also say that epinephrine may be a good stopgap option for temporizing severe hypotension in an undifferentiated shock situation, and that is because epinephrine is so easy to push dose, right? When it comes to giving push dose, you can also push dose phenylephrine, but again, phenylephrine is not going to be as effective because the list of conditions where you would consider using phenylephrine is a lot shorter than epinephrine. So because epinephrine is so sympathetically promiscuous, so to speak, it works in a wide variety of situations, and it's easy to mix for push dose, right? And so you just take a 10 milliliter syringe. Take a 10 milliliter syringe. This is not a 10 milliliter syringe, but you get the deal. Take a 10 milliliter syringe. Draw 1 milliliter of cardiac epinephrine, that is 1 milligram per 10 milliliter, or a 1 to 10,000 concentration. Draw 1 milliliter of that, and then mix it with 9 milliliters of saline, and you now have a 10 milliliter syringe, and each milliliter in that syringe contains 10 micrograms of epinephrine, and then you give 5 to 10 micrograms, or 1/2, 0.5 to 1 milliliter IV push every 3 to 5 minutes. That's quick, easy, down and dirty push dose epinephrine. You push it, you kind of temporize the patient, and then that buys you time to get drips mixed and to get some of these other agents going. And so that's epinephrine. And then finally, an honorable mention, because it is technically a vasopressor, but it works via an entirely different mechanism, and that is, of course, vasopressin. And vasopressin actually works by agonizing V1 receptors in vascular smooth muscle, so it is generally considered a pure vasoactive agent. Vasopressin is generally not going to be a primary agent. Vasopressin is often going to be a secondary agent, often in the setting of septic shock, where you're already administering norepinephrine and or epinephrine, and you're adding another agent into the mix because a patient's not improving. And so there it is. Typically, you're looking at a typical dose of somewhere around 0.04 units per minute. Oftentimes, you're not going to titrate that, at least outside of the critical care setting. There seems to be some biological plausibility for an increased risk of peripheral limb ischemia that comes with vasopressin. There may be, but I'm not aware of like large randomized controlled trials that suggest this is necessarily the case, but there are case reports, there's biological plausibility, but oftentimes, vasopressin is used in patients with severe septic shock where they're already having distal perfusion problems, and so I think it's kind of hard to tease that out, that is, their fingers falling off, finger ischemia, losing fingers and hands and toes and things like that. Is that necessarily the vasopressin, or is it more related to the severity of the patient's underlying condition? I'm not sure, but it's still something that comes up, and I think it's something you need to be aware of. So that's kind of the down and dirty basic rundown of agents. I just kind of want to conclude talking a little bit about septic shock, because that's a very common area where we see vasopressors used. And so I just want to talk about a quick way of conceptualizing the vasopressor use in severe septic shock. So if you have someone in septic shock, typically your primary agent is going to be norepinephrine, all right? You're going to get your norepinephrine up, somewhere around 10 mics a minute, titrate it for a response. If the patient's not responding, you want to add some vasopressin into the mix. Usually or often people will also add a dose of steroids. We call this stress dose steroids. Commonly you're going to use something like hydrocortisone or Solu-Cortef, 100 milligrams in the adult patient, and that's going to provide that good mineral corticoid activity that you're not necessarily going to see in other agents like methylprednisolone or Solumedrol, which doesn't have the mineral corticoid or as much mineral corticoid activity as something like Solu-Cortef or hydrocortisone. So you start your norepinephrine, you optimize that, you add some vaso, maybe with a stress dose steroid. If that's not working, I would see about getting a look at the heart. If you could, if you have POCUS, point of care ultrasound, throw that on. See what the heart is doing. Is it a cardiac output issue, right? Are you getting some sepsis-associated cardiomyopathy? In that case, you probably want to look at adding some epinephrine. So now you're looking at 3 vasopressors at that point. The kidneys are going to be at high risk for taking a hit. You're almost certainly going to have an acute kidney injury, and that may go on to renal failure. So then you're going to want to look at getting the patient to somewhere where we can look at dialysis or possibly renal replacement therapy as a bridge to dialysis. So that's kind of the escalation scheme you can think about as far as it comes to treating refractory septic shock. And then just some other clinical pearls. If you're going to be giving vasopressors, or you may think that the patient may receive vasopressors in the near future, you can give them through peripheral vascular access, although you want to get as a large a bore IV as possible, preferably in a large peripheral vein in the, say, in the antecubital fossa. Preferably an 18 gauge or larger if you can get that in there. If vasoactive agents, a sympathetic vasoactive agent extravasation or infiltration occurs, you want to immediately discontinue that infusion. You want to get, if you have the ability to administer phentolamine, which is an alpha blocking agent, into that side, do so. And some people even recommend the use of nitroglycerin paste to the area, and that again is to prevent tissue necrosis and possible loss of the limb. And then the last thing I want to mention before I conclude is the fact that it is very important to ensure that you've addressed any underlying fluid volume deficits prior to adding vasopressors into the mix. Or if you are going to add a vasopressor, you are taking care of a fluid volume deficit at the same time, right? It is very poor form to have a completely unaddressed fluid volume deficit and then you start throwing vasopressors into that patient, right? So if there is any chance that there could be fluid loss, hypovolemia, fluid volume deficits, dehydration, hemorrhage, things like that, make sure that you are at least considering and taking actions to address underlying fluid volume deficits, either in concert, concomitantly with vasopressors, or prior to administering vasopressors. And that's kind of the basic down and dirty rundown of some of the common vasoactive agents you may run into and some of the clinical implications behind using them, when and how to use them. And I hope you all find this video helpful, and I hope you have a great holiday weekend, and we will see you in the next video. Take care, everyone.